Welcome and thank you for joining us today for the Intersectionality of Obesity, Cancer, and Health Disparities in Clinical Research webinar. My name is Mabinti Conte and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some quick information on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. Please submit questions throughout the presentation using the chat or Q&A box and select all panelists. A moderator will ask your questions and/or comments on your behalf at the end of the presentation. If you require technical assistance, please feel free to contact our host, Jenny Tweston, via the chat panel, and she'd be happy to assist you. Closed captioning is available and a link has been provided in the chat box. We also wanted to make you aware that today's webinar is being recorded. Also, as I am sharing my screen, if you move your mouse away from viewing application, it will unblock the screen so you can see all the wonderful presentations. And now I'd like to turn it over to Dr. Barbara Dunn.
And I'm very happy to be here welcoming you. I want to welcome the entire audience. We have a very large audience, and especially our three speakers. So I wanted to point out that the top title, Exploring the Intersectionality of Obesity, Cancer, and Health Disparities, is a global title for the entire month of 4 webinar sessions every Thursday. This particular session is the third, and it focuses on these topics in the context of clinical research. So we have celebrity clinical researchers. We were very particular about who we chose. And here you can see a summary of the topics. People who will talk about weight loss, diet, exercise, lymphedema in the context of cancer research, largely breast cancer, but other cancers will be mentioned. And in particular, we want to emphasize the challenges to accruing minority and underserved individuals to clinical trials. That's a main theme of all the talks. So now I will mention Worta McCaskill-Stevens. Dr. McCaskill-Stevens is a longtime colleague of mine and now my current supervisor. And she is the director of the program that runs all the community clinical trials for the NCORE program. And these trials are designed and conducted by the research bases throughout that are sponsored by NCI. And our speakers, Worta will serve as discussant. I'll turn it over to her in a minute. I just want to mention our speakers, Jennifer Ligibel, Khalid Matin, and Kathryn Schmitz. And now let me turn this over to Worta. Here's a very nice picture of Worta. You can see she's the chief of this group that runs these huge trials. And Worta, take over, please. Thank you.
Good afternoon. My next slide, please. Good afternoon, and thank you to the Planning Committee for allowing me to provide a few comments about this very important and expedient topic, especially as we build on the shoulders of accomplishments of the past 50 years in cancer research. The previous sessions in this series discussed the why of the intersectionality of obesity, cancer, and disparities, followed by discussions on basic and translational research, all of which have propelled us into asking the question, are there ways in which this intersectionality can be incorporated into clinical trials? And what are the venues for the conduct of these trials? And thinking about this, let's examine some of the associated challenges in this space. Nearly 20% of US cancer diagnoses are related to excess body weight, alcohol intake, poor diet, and physical inactivity. Having access to food, to healthy food, is a major consideration as we think about our trials, but also access to an inclusion of dietary menus and trials that are appealing to different cultures. Interventions are often complicated by the quality of the traditional dietary, food dietary diaries, and unsustainable dietary behavior. even when there have been successful changes in dietary behavior and menus, at the completion of the trials, we have been unable to always sustain them in different populations. Enrollment of racial ethnic populations and other underserved populations into clinical trials requires a team that is invested and integrated into the communities where the populations live. Far too many of those with the heaviest burdens of cancer and obesity experience disparities in overall care and cancer care in general. It's also important to remember that many patients receive no medical care of their chronic diseases or of their time of cancer. Furthermore, where you live determines the feasibility of adhering to trial requirements. The diversity of the practices and the institutions determine the capacity and the feasibility of implementing interventions in different types of trials. Will innovative lifestyle interventions with the potential to improve health outcomes align with the behaviors, work patterns, family structures, income of rural patients, for example? Trying to balance the clinical trial design with practical purposes is also a challenge. Increasingly, clinical trialists like to ask for additional information, particularly on social determinants of health, to complement the clinical outcome, the clinical data, and increasingly clinical annotated specimens in clinical trials. How do we accomplish this in low resource health institutions? And finally, management of chronic comorbidity, or the appropriate management of chronic comorbidity, is a major research gap, is also a challenge. This is an ongoing interest, certainly in the NCI Clinical Trials Network, in which we are trying to develop partnerships between primary care physicians and other specialists who participate in the care of patients. Next slide, please. If we use the prevalence of diabetes, type 2 diabetes as an example, shown here are diagnosed and undiagnosed cases with type 2 diabetes. Clinically, we see that there are certain disparities between genders, also in non-Hispanic Blacks and Mexican American, and not shown here in Native Americans. But importantly, do these undiagnosed cases at the time of diagnosis result in physician biases in enrollment into clinical trials? Do the diagnosed cases complicate the treatment? We know that peripheral neuropathy is associated with diabetes. We also know that there's chemotherapy-induced peripheral neuropathy. We have experienced successes in reducing diabetes-related complications by technology, by cardiovascular risk factors, management of glycemic control, yet little success in decreasing overall disparities have occurred. Next slide. Here we show reasons to maintain a healthy weight and stay active. In the United States, excess body weight is associated with nearly 5% of all cancers in men and 11% in women. This anatomy chart shows the 15 cancers in men and women that are associated with obesity, physical activity, and both. Most of these cancers have symptoms either before or at some point during the treatment and diagnosis of cancer. In addition, many patients have treatment-related toxicities associated with them. We know that both cancer as well as chronic diseases increases with age, and with the significant epidemic across all age groups, this becomes a major concern. These intersections involving these two conditions and the significant overlying health disparities give way to research opportunities in academia and the real-world community settings. Our esteemed speakers today will shed light on these opportunities through their experiences in the conduct of clinical trials in various venues. So with this, I'd like to introduce our first speaker, who is Dr. Jennifer Ligibel, who is the director of the Henry Zakim Center for Integrative Therapies and Healthy Living. And she is also the Associate Professor of Medicine at the Harvard Medical School. Dr. Ligibel.
Thank you very much, Dr. McCaskill-Stevens. And thank you to the organizers of today's symposium for inviting me here today to speak about weight loss as a part of breast cancer treatment. Let's see if I'm able to advance the slides yet. This takes a second. There we go. All right. So what I hope to do over the next few minutes is provide a very brief overview of the data linking obesity to both the risk of developing breast cancer and a prognosis in individuals who are diagnosed with the disease. And then I'm going to talk about the design and implementation of the breast cancer weight loss trial, a phase 3 study designed to evaluate the impact of a weight loss intervention on disease outcomes in a diverse population of breast cancer survivors who are overweight or with obesity at the time of their breast cancer diagnosis. So as a bit of background, as Dr. McCaskill-Stevens already alluded to, we know that there is an association between obesity and the risk of developing malignancy. At this point, there have been thousands of reports that have looked at the relationship between excess adiposity, measured through body mass index, through waist-hip ratio, body composition, or other measures, and an individual's risk of developing cancer. The International Agency for Research in Cancer convened an expert panel in 2015 to evaluate this evidence. And as a group, we determined that there were at least a dozen malignancies for which there was clear and consistent evidence that excess adiposity was associated with an increased risk of developing that malignancy. I'm primarily going to speak about breast cancer today, and postmenopausal breast cancer was one of the malignancies for which there was clear and consistent evidence that excess adiposity increased risk of the disease. This analysis also demonstrated for the first time emerging evidence that male breast cancer, while fairly uncommon, also appears to be associated with excess adiposity. We also recognize that the relationship between obesity and breast cancer does not stop with its relationship to breast cancer risk. And in fact, there are many, many studies which demonstrate that body weight at the time of breast cancer diagnosis is related to an individual's risk of recurrence and mortality in individuals with early stage, potentially curable breast cancer. This meta-analysis was published now a few years ago by the World Cancer Research Fund. It included more than 82 individual reports looking at BMI at the time of breast cancer diagnosis and the risk of breast cancer-related and overall mortality. The investigators found that women with obesity at the time of breast cancer diagnosis had a 35% higher risk of breast cancer-specific mortality as compared to individuals whose body mass index was in the normal range at the time of diagnosis. The risk of overall mortality was increased by 41% in individuals with obesity. The other thing that was very important about this meta-analysis is that it was large enough, incorporating more than 250,000 women with early breast cancer, to look at younger and older women. We know that the relationship between body weight and breast cancer risk is much more significant in postmenopausal women as compared to younger women. But this analysis looking at the relationship between body mass index and cancer outcomes in individuals with early disease demonstrated a strong association between obesity and poor outcomes in both younger and in older women. Now, these relationships between obesity and breast cancer are especially problematic given the rising prevalence of obesity, not just in the United States, but around the world. This figure depicts prevalence of overweight and obesity in countries around the world over the last 50 years. You can see the rapid rise in the proportion of US adults who are overweight and obese over this period of time. But even countries where overweight and obesity was once uncommon, rates have been climbing. We also recognize that the prevalence of obesity is not distributed evenly across racial and ethnic populations, and you'll hear much more about this in later talks in this session. These data were collected in the 2000s in the United States and the United Kingdom. They demonstrated that the prevalence of obesity was relatively constant in men, but was very different in women across racial and ethnic groups. You see here that the prevalence of obesity was about 50% greater in Black women in the United States as compared to white women. And the risk of obesity in Hispanic populations was also increased in the United States women. This was also seen in the UK, although overall levels of obesity are a bit different there. Now, although we know a lot about the relationship between obesity and breast cancer outcomes, Most of that evidence comes from white populations, and in fact, there are very few studies that have specifically looked at the relationship between obesity and cancer outcomes in racial and ethnic minority breast cancer survivors. This report, published a few years ago, looked at outcomes in the CARE multi-ethnic cohort, which included about 1,600 Black breast cancer survivors and 2,900 white survivors. The analysis demonstrated a very strong relationship between body mass index and outcomes in white breast cancer survivors. And you can see on the curve on the right side here, significantly worse outcomes in women who were obese at the time of breast cancer diagnosis. The analysis demonstrated that Black breast cancer survivors had poor outcomes regardless of body mass index. This is one analysis, and much more needs to be learned about the relationship between body mass index and other lifestyle factors and outcomes in Hispanic and Black breast cancer survivors, but this does demonstrate poor outcomes in this group. So given these findings, this growing evidence that obesity is linked to outcomes, these gaps in our knowledge about how lifestyle factors such as body weight impact outcomes in minority breast cancer populations, we sought, now almost a decade ago, to evaluate the effect of weight loss achieved through a lifestyle intervention on the risk of breast cancer recurrence and mortality in a diverse group of women with breast cancer who were overweight or obese at the time of their breast cancer diagnosis. This work ultimately led to the design of a phase 3 randomized trial supported by the National Cancer Institute called the Breast Cancer Weight Loss or BWEL study. This trial was designed to enroll 3,136 women diagnosed with stage 2 and 3 hormone receptor positive, HER2 negative, or triple negative breast cancer who had a body mass index of at least 27 kilograms per meter squared, and randomized those patients after the completion of their standard breast cancer treatment to a 2-year telephone-based weight loss intervention plus health education materials, or to a health education alone group. The study had an ambitious goal of enrolling 30% of its participants as racial or ethnic minority breast cancer survivors. A trial has been conducted through the NCTN and NCORE system. The primary outcome of this trial was to look at the impact of this weight loss intervention on invasive disease-free survival, which is an aggregate endpoint that includes both local, regional, and distant breast cancer recurrence, a second primary breast cancer or other primary cancer, or death from any cause. Secondary objectives of this trial included looking at the impact of this weight loss intervention on breast cancer-related mortality, overall survival, the incidence of comorbidities like diabetes and cardiovascular disease, evaluating the relationship between weight loss and outcomes, and looking at the impact of the weight loss intervention on subgroups defined by the hormone receptor status of the tumor and the menopausal status of the patient. With a planned sample size of 3,136 patients, this study has 85% power to detect a hazard ratio of 0.8, which equates to about a 4% improvement in disease-free survival in women randomized to the lifestyle intervention arm. One of the challenges that faced us as we designed and began to implement this trial was, how do you implement across more than 1,500 diverse breast cancer patients a weight loss program that will work? One of the things that was the most important to us in this study was that we would enroll patients from across the United States and Canada, and we would enroll them not only in big cities, but also in rural areas, that we would enroll older and younger women. And we wanted to develop a lifestyle intervention that would work to help women lose weight, regardless of where they came from, who they were, what age they were, or how they were enrolled in the study. So the first thing that we did was develop a standardized, centrally delivered intervention. As a blueprint, we used lifestyle programs that had been tested in other large groups of patients in the setting of clinical trials, using the diabetes prevention program, the Look Ahead, and the LISA study. Most of these studies, however, used an in-person intervention, and we changed this to be based through telephone and other remote counseling to implement the weight loss program. And we also updated these materials, recognizing that in 2016, when this study started, people were interested in using technology to try to incorporate weight loss in their lives, and also recognizing that our sense of what led to weight loss has shifted over the years from being a purely low-fat diet program to really focusing on dietary quality, overall caloric content of food, portion control, and increased physical activity. Each patient was paired with a lifestyle coach based at Dana-Farber, and they received 42 telephone calls over the course of the 2-year intervention. We also developed standardized lifestyle intervention goals, including a standardized weight loss goal, caloric restriction, and physical activity goals. Despite the standardization of the program, we really wanted to be able to tailor this intervention, recognizing the diverse group of individuals we were attempting to enroll. We were fortunate that we were able to develop partnerships with a number of groups that donated their products to help our patients achieve weight loss through the things like wireless scales, activity monitors, protein meal replacement shakes for patients who wanted them, cookbooks, and food scales. We also developed a toolbox approach that allowed us to develop a lot of flexibility in terms especially of the dietary programs that patients followed. Since we were focusing mostly on caloric intake and overall dietary quality, we were able to incorporate things like an Indian diet, a Caribbean diet, diets that focused on macrobiotic or low gluten foods. And this really allowed us to tailor this intervention to patients in different parts of the country from different racial and ethnic groups. This also allowed us to help people that were struggling with their weight loss goals by incorporating things like increased physical activity, by giving people things like sneakers or coupons for when we were able to work out in gyms, things that will allow them to make this intervention more able to target weight loss for the individual patient. The other thing that we did through this study was develop a technology platform that allowed our participants and coaches to connect in different ways. 2 years is a long time to try to work with patients through a completely telephone-based program. So we developed a web portal that brought in their physical activity, their dietary data, and their weights over time. The web portal also allowed us to place all of our telephone calls through a secure portal, to have an email system where patients could interact with their coaches. And it also allowed us to record our calls so we could make sure that the intervention was being delivered in the same way to patients, no matter where they were calling in from. These approaches were very successful. Our study was open to enrollment in August of 2016, and you can see our enrollment curve on the right side of this slide. We were very, very successful in meeting our enrollment goals month by month until the very end, when COVID threw us a little bit off track. We were also successful in achieving weight loss. In 2019, we passed an interim analysis demonstrating a change of at least 4% of baseline weight in our intervention group versus our control group. Our study closed to enrollment last month and ultimately enrolled patients from more than 600 centers across the United States and Canada, and had a total enrollment of almost 3,180 patients. We were also very successful in retention, and this is one of the things that we followed carefully. But as of our analysis in May, we had more than 91% of our patients who were continuing to be followed by the study, with more than 86% of patients completing the 2-year intervention or control period. And I know I'm running out of time, but I wanted to share with you very briefly who's participating in our study to see how we've done with our goal of enrolling a very diverse group of patients in the study. So our average age, you can see about 40% of our patients are less than 50. We have 17% of our patients who are age 65 or greater. Our average body mass index is about 34.5 kilograms per meter squared. About 80% of our patients have hormone receptor positive cancers and 20% triple negative. Very important to us, we have found a very wide range of socioeconomic status in our patients, really ranging from household incomes of less than $20,000 per year to more than $120,000 per year. We've also had geographic diversity, with patients being enrolled from 49 of the 50 US states, as well as 7 Canadian provinces. I think most importantly, although we did not achieve our 30% minority recruitment goal, about 26% of our patients are from racial or ethnic minority populations, including about 13% of patients are African American, and about 7% of our patients are Latina. This fell a little bit short of our overall goals, but overall we're quite happy that we were able to enroll a quarter of our patients from racial and ethnic minority groups, and so have almost 600 patients who are from a racial or ethnic minority population that we'll be able to follow over the coming years to determine how this lifestyle intervention impacted their risk of cancer recurrence and mortality, as well as other important outcomes like comorbidities. So I wanted to just finish with an acknowledgement, thanking all of the thousands of women who have participated in this study, as well as the many, many collaborators. As Dr. McCaskill-Stevens said, to run a trial like this successfully and enroll a diverse group of patients, you need many collaborators. So thank you very much, and I will turn this back over to Dr. McCaskill-Stevens.
Dr. Ligibel, thank you for an outstanding presentation. I'd like to move on to introducing Dr. Khalid Matin, who is from the Virginia Commonwealth Massey Cancer Center. He's the interim chair of the Division of Hematology, Oncology, and Palliative Care, Department of Internal Medicine. Khalid, welcome.
Good afternoon. Thank you, Dr. McCaskill-Stevens. It really is a pleasure for me to be able to give this talk this afternoon. Hoping I have progress the slides here. I haven't received the control of the slides yet. All right, thank you. So today I'm going to be talking to you about the VCU Massey Minority Underserved NCORS experience as regards to the triad of obesity, cancer, and disparities. If you could go to the next slide, thank you. For us at VCU Massey, I think what we do and what's defined by us is a reflection of where we're situated. We are in downtown Richmond. There's a lot of history with the sites where we're located. We have the West Hospital, which is at the site of the Virginia ratification of the U.S. Constitution in 1788. On the campus is the first African-American Baptist church built in 1841. And right behind the big building that you see, the main hospital, is the White House of the Confederacy. So really that's a paradox that really defines us here in Richmond and our minority underserved NCOR. Next slide, please. I wanted to put this quote up because unfortunately it is as important and as poignant as it was over 50 years ago when Reverend Dr. Martin Luther King spoke these words. And I think it really speaks to the fact that while we've made progress in a lot of things, clearly when it comes to health inequity, we really still have a lot of work to do because there is a lot of gap between those who have access and those who don't. Next. Next slide, please. Can we go to the next slide? So while that's being worked on, I think what the next couple of slides are going to show us is really the dynamic difference between the different ethnic groups as regards to obesity. As Dr. Ligibel very eloquently already spoke to us, is about the association of obesity with cancer. So we know clearly that that's where a lot of the pathogenesis starts. And unfortunately, when you have significant differences between different ethnicities, therein lies a lot of the problem. So what I was hoping to highlight in the next couple of slides is the dramatic difference that you will see that's evident between the white population, the non-Hispanic white population versus the non-Hispanic Black population and how much of a significant contrast there is. And the data is basically collected through the behavioral risk factor surveillance system, which was a method of basically an ongoing method of calling in patients and having them self-report their height and weight and calculating their BMI based on that. Once that's tabulated, then different states, according to different levels of obesity, are stratified, and that's hopefully we'll be able to get to those slides, can really show you which states fare better, whether it's a white population versus the African-American population. It looks like we're still having a problem with slides.
Yes, just one moment now. Thank you. So sorry about that. You should now have slide control.
There we go. All right. Let's see if I can move to the next. All right, so this is the first slide I was alluding to as regards to the non-Hispanic white population for the years 2017 to 2019. As you can see, there's a wide variation amongst the states, even for just looking at the white population. Clearly, a lot of states have a lower incidence of obesity. The ones that are in yellow and green are the ones that fare better. The ones that are in the orange and burgundy are the ones with the highest rates. As is evident on this map, the higher rates of obesity tend to be in the Midwest and South, with Minnesota and Florida being the exceptions. And as we look at the next slide, which shows the Black population, there is a significant increase across all of these states in terms of the higher rates of obesity of over 35% for the vast majority, even states like California that do remarkably well when it comes to the white population, low rate of obesity are in the highest range here. So that's really the disparity that we need to address as we talk about the risk of cancer with obesity. Coming down to our state of Virginia as relates to our minority underserved NCOR, I want to highlight a couple of things. The side-by-side maps look at the Virginia overall cancer mortality rates with Virginia's adult obesity rate by counties. In the dark black lines, basically within this is our VCU Massey catchment population. Now our NCOR sites, some of which are right at the periphery and one outside of that. So actually our NCOR catchment population goes beyond, but this is our cancer centers catchment population. As you can see within that, there is a very strong correlation with obesity and the cancer mortality rate. And that's has been part of some of the work that investigators at our cancer center have done. And it's an area of continuing research and addressing those concerns as well. Certainly there are areas outside of our catchment population that we tap into a little bit with our NCOR affiliates, and we continue to work with those counties as well. Next, looking at similarly side-by-side maps of the overall cancer mortality by county versus the minority rate. And again, similarly, you'll see, especially for our catchment population within this dark black line, is that there's a fair degree of matchup between higher minority rate counties and higher cancer mortality. So while some of this is obviously more closely related to the rates of obesity, we can also see that it matches up with that as well. And we do know, as evidenced by the data I showed earlier regarding the whole country and the data that Dr. Ligibel shared with us, that there's higher rates of obesity in minority populations. So clearly it gives us a direction in terms of which counties, which part of our catchment area, and which part of our NCOR we need to target more strongly. This is an interesting map, basically two maps looking at hotspots as relates to either the obesity rate or as relates to the minority. So again, we're looking at the overall cancer mortality by county, and then seeing really where are the hotspots as relates to either the obesity or to minority rates. And again, it gives us an idea of some of the counties we need to target. And there's some overlap between the hotspots as they relate to minority rates and also for obesity rates. The other variance that we see in the state of Virginia, as evidenced by this data from the United Health Foundation, is there's between different ethnicities, there's differences in the obesity rate. And as you can see, specifically the one area of interest I wanted to point out is within the state of Virginia, we have, unfortunately, a higher rate of obesity among the Black population as compared to nationally for the Black population, about 4% higher. And the other thing to point out, an area that we are concerned with and addressing, is the obesity rate that's higher in our state for people who have less than a high school education. So again, gives us a direction and more, in terms of areas we need to target within our state. There's obviously a lot of contrast in terms of where you are within the state of Virginia. These are stark contrasts as evidenced by a county, Lexington City, basically, which is a university town out in Appalachia, where basically the obesity rate is one of the lowest in the state at 19%, whereas King and Queen County, which is within our catchment population, and the rate is as high as 52%. And obviously, there's a lot of different factors, but it gives us an idea of where we need to have targeted education and interventions within our state. So as we look at the data for our catchment population versus the non-Massey catchment population versus Virginia versus the US, that we can see that we have some of the counties that are worst affected by obesity and cancer mortality. And we can see that our rate of obesity is about 35% within our catchment. For the non-Massey catchment population, it's 30%, which is for the rest of the state, which is pretty close to what it is for the entire country. And this really applies to whether we're dealing with either a rural or an urban population. They are both higher than the average for the state and higher than what's out there outside of our catchment population. So I do want to highlight our minority underserved NCORE. We have affiliate sites around the state. Within the Richmond area, we are here in downtown Richmond. We also have a satellite site across the river, James River. And then we have one of our partners is the Virginia Cancer Institute, one of our affiliates, and they are spread out throughout the suburbs of the Richmond metro area, the McGuire VA, so that we are able to get our veteran population also access to clinical trials. And then around the state, as far north as Shenandoah Oncology in Winchester, Central Lynchburg in the city of Lynchburg, Fredericksburg Hematology Oncology. We have our own site down in CMH in South Hill. And then the rest of these areas are part of the Riverside Oncology Group, which is our newest affiliate that allows us to really cover the Chesapeake Bay area, really giving us a wide range of coverage throughout the state and diversity in our patient population for our NCORE. Traditionally, we have done well with minority accrual. 2020 for us, even by these numbers, was a little bit of an off year for us, but I wanted to highlight that because it was a tough year with COVID and a lot of accrual. We did take a hit, and it unfortunately disproportionately affected our minority population due to access and other reasons. But we have continued to focus on minority accrual as being something important, given our minority underserved NCORE status and the mission of the Massey Cancer Center. And as you will see, historically in the past, we've been more at the 30%, 25 to 30% mark. But when it comes to CPC accrual and biospecimen accrual, we've been able to maintain that. The treatment accrual is one that we're continuing to work on, and we're optimistic that that will be back up to closer to the 30% mark in the coming year as things return to somewhat normal post-COVID. I did want to give a shout out to Dr. Ligibel's study, the BWEL study. This is a study that we really enjoyed having open and accruing to. We certainly wish that there were more clinical trials like this, because there was a wide appeal for this, whether it was here at VCU Massey in Richmond or at our affiliate sites around the state. Our accrual over the years it was open was steady. Unfortunately, in 2020, it did drop off for the reasons I mentioned with COVID. But the good part was we got really across the board accrual from all of our affiliates. And in the end, you can see overall total, we had 42 accruals, and we had a good mix of, different diversity in our African-American and white population, pretty much across the sites, especially the two sites that are in the Richmond metro area, were the ones that did the best in terms of getting minority accrual, but even our minority sites out in Fredericksburg and Lynchburg were able to accrue well to minority populations. Now, some of the work that is currently being done, I wanted to highlight, and frankly, some of the challenges we face. As I highlighted previously, we have some counties that really have significant risk factors in terms of the risk of obesity, a higher cancer mortality, and these are areas that over time VCU Massey has really targeted for some of the community engagement. So these are 4 areas where these buildings that are being shown are basically community engagement centers that have been run now for years. There's been a lot of good work, community education and partnerships with stakeholders in these communities to really try to improve on a lot of the problems that we are seeing. As you will see, areas like Danville have a high minority population, unfortunately a high rate of smokers, high rate of obesity, low income, and significant colon cancer mortality. Oops, sorry. For Brunswick, similarly, high minority area, high smoking rate again, very high rate of obesity, a significant rural population, so sometimes access to healthcare is an issue there, and colon cancer screening is low. Interestingly, Brunswick and Danville, these are two areas that are part of one of the cancer hotspots, one of 3 areas in the country that have some of the worst cancer mortality in the country. So clearly an area we're going to continue to stay engaged and work with the population here to increase cancer screening and reduce cancer mortality factors like obesity and smoking. Petersburg is more of an urban area that's not far from Richmond. 76% Black population, 24% smokers, which is the highest in the state, 40% obesity. A lot of food insecurity in this area due to food deserts, severe housing crunch as well for a lot of the people, and life expectancy is way below the average for the state of 68 years, and we see increased cancer mortality in these areas too. Richmond City itself, 57% Black population, 20% smokers, 31% obese, and significant increased drinking, 22%. And we've seen a rising trend in liver mortality here. So these are all areas that there's a lot of work we're doing and we need to keep doing to improve, but we can be targeted in our approach, in our messaging to some of these communities based on what the main area of insult is in that area. So these are some of the projects that have been done, and a lot of this work has been done by Dr. Shepard, Vanessa Shepard, and a group, and it's basically been to have communication with community stakeholders and other members in the community. A lot is centered around education, continued engagement. One of these is to address rural food insecurity and obesity. This is one of our cancer survivors who himself has advanced cancer, but he wanted to do something for his fellow neighbors in his community to teach them and to tell them, look, don't wait long like I did and make sure you get your cancer diagnosed early. And his focus was on obesity and healthy food choices. Then there was a trial for Cancer Prevention Connect. We're looking at supervised exercise for women to enhance them to lose weight, and 40% of women were able to achieve greater than or equal to 5% weight loss at 3 months. So things that have been done and have been successful. Then there's been a drive to focus on seniors in urban areas, and especially in an area like Petersburg, where we know there's obesity and it's a predominantly urban population. And some of these interventions have led to either maintenance or decreased BMI and also reduction in waist size. Then there's been the Stepping Stone program to targeted primarily at Black patients, survivors who have a BMI of 25 or higher, doing supervised exercise, tailored education, reducing their BMI, and increased physical activity. And finally, another program was the FRESH program, looking basically to target audiences, survivors and caregivers. The format had to be changed last year due to COVID. They were able to do it through webinars, weekly evening sessions, and really having a team approach where you had a health coach, a registered dietitian, a health educator, and using technology with Fitbits and then cookbooks and videos to really instruct people on healthy living. And these are some of the comments from some of the participants who took part who felt like they got something out of it. So at the end, I want to mention some of the challenges. Also, this is a study that was published by Dr. Vanessa Shepard and her group in breast cancer. The challenges really are multifactorial, and I'll touch on some of the ones vis-a-vis tackling obesity and then also regarding clinical trials. One of the key issues has been the general low knowledge and awareness about nutrition in cancer survivors in some of our catchment population. And we continue to work with and make inroads in that through these community health centers that I mentioned in my last few slides. There is, we know, modest levels of physical activity in survivors. That's an area we need to continue to work on. Physical activity in our catchment population is found to be lower in our African-American survivors versus white survivors. And that's why we need to have the continued engagement that we have. In-person interventions can be challenging for trials, and especially in COVID, it has been a challenge. And that's why embracing technology and using webinars and other things and social media has been very helpful. The things I want to bring up at the end regarding clinical trials are really that we struggle with within our NCORE as we discuss these clinical trials on a regular basis is, are our clinical trials really applicable to our patients in the community? And we do with certain trials struggle with that. Certainly the BWEL study is something that we really found had high applicability and was really embraced by all of us. The other part is clinical trial myth busting. There's a lot of misinformation out there, and sadly, a lot of it is through the social media and otherwise. So we've continued to work on that. Implicit bias is an area we continue to work on, and COVID-19 has been a challenge as well this year. And finally, just want to acknowledge that we were really honored to have First Lady Dr. Jill Biden visit us to acknowledge us for some of the work that's been done vis-a-vis the minorities and underserved population, but we realize there's a lot that obviously still needs to be done. And finally, just wanted to acknowledge our team, without whose help none of this is possible. Dr. Vanessa Shepard, who's our chair, Department of Health and Behavior Policy, Dr. Tosis, and Kristen Campbell and Wanda Hunt, who really help out with our NCORE affiliate sites. Thank you for your attention.
Thank you so much, Dr. Matin, for that comprehensive and outstanding presentation. Our third speaker is Dr. Kathryn Schmitz, who is at the Pennsylvania State Cancer Institute. She's the Distinguished Professor of Public Health Sciences at that institution and Director of Oncology, Nutrition, and Exercise Group. And with that, Dr. Schmidt, welcome, and we're looking forward to your presentation.
There you go. Thank you. I couldn't find the unmute button. Hello, everyone. I was just so delighted to hear both of those presentations. Thank you so much for the invitation to speak with you today. And I was delighted to hear Dr. Matin say that they enjoyed having BWEL. We have a protocol coming forward from NRG Oncology, and we're moving through the process that, you know, I really think that the BWEL study set up the potential for more lifestyle intervention studies through the NCORE system. And so thank you, Dr. Ligibel, for all of that remarkable work. My assignment today was to speak with you all about obesity, exercise, and lymphedema within 2 multi-ethnic RCTs of breast cancer survivors. So as background, I want to point out that there is actually a really lovely review that I wrote in collaboration with an amazing team from the TREC initiative back in 2013 that is very relevant to this topic, called The Impact of Obesity on Cancer Survivorship and the Potential Relevance of Race and Ethnicity. Although it is from all the way back in 2013, it still holds very much true and is kind of an underpinning for a lot of what I'll say today. As a start, I'll note that obesity does increase the risk for lymphedema with about an 8% increase in odds for each unit of BMI. We also know that race is associated with lymphedema risk, but if we look at one particular study and we look at the fact that there is an absolute incidence difference between Black and white women in this study, when you then adjust for age, obesity, hypertension, and the removal of 10 or more lymph nodes from the axilla, the racial difference is no longer significant. This is our first clue that there are upstream issues at play if we are looking at differences in the lived experience of Black women versus white women who have had a diagnosis of breast cancer. The other thing we can note is that axillary dissection is certainly associated with lymphedema risk, and there is observational evidence that Black women with node-negative cancer are a third more likely to undergo axillary dissection as compared to white women. So I am delighted to be able to amplify and elevate the work of one of my former mentees, Laurie Dean, who was my postdoc at Penn during the TREC initiative and who just got tenure at the Johns Hopkins School of Public Health. One of the papers that Laurie wrote with me was about race or resource. For this particular analysis, she looked at baseline data from the Weiser Survivor trial with almost half and half Black and white women. And her outcome was lymphedema severity. She was looking at interlimb difference and the magnitude of interlimb difference. And so despite what I just told you from sort of the observational literature, she did not find in this cohort that severity of lymphedema in a cohort of women who all have lymphedema was associated with race. There was no association with race. There was also no association with BMI. What she found the strongest association with lymphedema severity was education as a proxy for resources. What was also associated with lymphedema severity was the number of years since treatment for breast cancer, axillary dissection, not surprising, and also related to resources, how well women did with their lymphedema self-care. Lymphedema self-care requires equipment. It requires that you've been taught how to do it. It requires repeated training. And so if you don't have the resources, including the time resources, to be able to get to that, then your lymphedema is probably going to be more severe. Laurie did another analysis, taking women from both the PAL trial and the Weiser Survivor cohort, bringing them together. 40% of the cohort for this analysis were Black women, and 47% of her study cohort had lymphedema. She asked these women about their health-related out-of-pocket costs over the past year. And what she noted was 112% higher out-of-pocket costs for women who had lymphedema compared to women who did not have lymphedema. She also did, this was a mixed methods approach. This was one of multiple studies that came out of her K Award. And she did some semi-structured interviews with a subset of these 129 breast cancer survivors. And what she found was that lymphedema was really a cascading issue that spoke to an issue of long-term burden that led to delays in retirement and reduced employment. And for many women, one of the struggles was the inability to access adequate lymphedema care. And so what we have here is a situation of an absolute difference of these issues of lymphedema incidence across race, and then a greater financial toxicity likely in the Black women because they're more likely to have the diagnosis of lymphedema. So what we've done is 2 large randomized controlled trials on lymphedema and exercise, one called the PAL trial and one called the Weiser Survivor trial. And I'll describe those 2 in just a moment after I tell you about the recruitment for one of these trials. The recruitment was the same for the 2 trials. So I'm telling you about Weiser Survivor. The situation was very similar for PAL as well. And here I'm getting to highlight my mentee, Katie Sturgeon's work. She was a postdoc with me during TREC and is now an assistant professor at Penn State. So we knew that Black women were more likely to experience lymphedema. The Weiser Survivor cohort was 351 women with lymphedema. And so we sought to over-recruit. We did this trial in the setting of Philadelphia. And so we had an enriched cohort in which to try to recruit Black women. We had 3 methods that were our primary recruitment methods for both of these trials. We sent letters to women based on the state cancer registries of Pennsylvania and New Jersey. We also used hospital-based registries, and those 2 approaches together netted us nearly 75% of our sample. We also had some passive print materials and websites and whatnot that are typical for a trial of this size, but we found that we were not keeping pace with our rate of recruitment that we needed to have in order to achieve our goal of 350 women randomized into the trial. So what we recognized was by calling some women who said, no, I don't have lymphedema, I'm not interested in your trial, we called them anyway and said, can we just ask you a few questions? And it turns out that some proportion of those women actually had symptoms of lymphedema and they didn't know it. So we invented something called our educational session that was something that we took on kind of a traveling road show to area hospitals. It was a bit of a health fair, and then we also did a lecture and talked about many of the issues that face breast cancer survivors, including but not just lymphedema. And we did lymphedema screenings, we did, their BMI and a bone scan and, a number of things for them. About 10% of our sample came out of those educational sessions from women who previously had not been diagnosed with breast cancer-related lymphedema, just showing, again, that this is an diagnosed condition. So we didn't see any difference in recruitment success by race. If we sent letters into an area that had a lot of Black women, then we had more Black women that responded to our letters. We didn't see that we actually had any difficulty with recruiting minority women. So what drove this? One was the fact that we were doing this in a setting where there was a larger proportion of minority women. Another was that we partnered with community hospitals. We didn't expect everyone to come to Penn. We went to Fox Chase, we went to Einstein, we went to all of the Delaware County, we went, to all of the various hospitals and did our educational sessions. We did as many measurements as we could in those settings. We did the interventions in those settings. So we tried to make it geographically easier. The other thing that was very important was having a racially diverse staff. We wanted to make sure that if a woman called or came for a consenting session, that she was just as likely to talk to someone of her own race as she was to talk to someone of a different race. We also regularly monitored our return on investment for any kind of approaches that we had for our recruitment and shifted, based on monthly reports on how things were going with recruitment. Finally, and this was kind of a secret sauce for me for both the PAL trial as well as the Wiser Survivor trial, I specifically and pointedly hired individuals who had master's in social work training, because that is a degree that is associated with the ability to have really outstanding conversations and build excellent relationships, and to help with recruitment as well as retention. So Renata Hackley, who is pictured here, was our outstanding recruitment coordinator for the Wiser Survivor trial. We also, for retention, again, our MSW and the building of relationships with all of the participants was a big key there. We also did parties, so you can see the staff, circa 2013, all dressed in funny costumes, standing in front of what's called a step and repeat. And so we would give people awards, we would update them about what was happening in the trial, and we would, put funny costumes on them and take their picture. We did these several times a year, and they became very popular with our participants. We sent cards for everything from a birth of a grandchild to a death in the family to a birthday. And all of these things taken together were very successful. We had a 92% retention rate in the PAL trial, and we had an 80% retention rate in the Wiser Survivor trial. So now to describe these two trials, the physical activity and lymphedema trial was a 1-year randomized controlled trial with twice weekly progressive strength training, facility-based. First 13 weeks were supervised by a YMCA-based trainer, and then they kept going to the Y on their own for the remainder of the full year, and then there was a non-exercising control. Our primary outcome was to determine whether or not we saw any changes in lymphedema-related outcomes. And just to explain, although it was a single grant from NCI, this was really two separate trials within one grant, because we recruited half the sample with lymphedema and half the sample at risk for lymphedema and randomized within lymphedema status. The results of this trial were published more than a decade ago at this point in New England Journal and JAMA. And to summarize some of our findings, twice weekly slowly progressive strength training was found to be safe for breast cancer survivors who had lymph node removed, including those with and those at risk for lymphedema. That's Old news now, thank God. This was really provocative at the time that it was, a new publication. We also found that the risk of lymphedema flare-ups was decreased by half, which brings to mind the possibility of this being a cost-effective intervention. Among women who were at risk for lymphedema at the time that they entered the study and who had 5 or more nodes removed, the risk of a 5% increase in arm swelling, which is a definition, it's one of the definitions of onset of lymphedema, was reduced by 70%. This is a prevention effect. It was a secondary outcome. We did see substantive strength improvements, and we saw increases or improvements in body image and skeletal muscle mass, and preventive reductions in physical function as compared to what happened in the control group as well. I'm glad to say that the PAL intervention is now a clinical program called Strength ABCs that's paid for by insurance and available in over 700 locations across the US. Physical therapists, occupational therapists, nurses, exercise trainers can pay $125 to learn how to deliver this intervention. And it's happening. It's happening all over the country. So our remaining questions after we finished the PAL trial were, really with regard to the exercise intervention, could we do this in a home-based intervention? We had pretty sharp criticism about how intensive that intervention was. We also had questions about weight loss. The Wiser Survivor trial did have 4 groups in it, but my assignment today was to talk about the exercise. And so that's what I'm going to talk about. So the Wiser Survivor trial, the exercise protocol, we added walking. We still had the slowly progressive resistance training. The instruction and monitoring was now just 6 weeks of weekly sessions to learn the protocol with weekly check-in calls throughout the entire year, and monthly in-person training sessions. We gave them adjustable dumbbells and a step, and we provided lymphedema garments to all of our participants. I'm sorry to say that we did not see any effect of our exercise intervention on any lymphedema outcomes in the Wiser Survivor trial, including mean interlimb differences or the clinical evaluation. So if we finalize, come to a conclusion about comparing these 2 trials, the PAL trial exercise program, as I said, supervised for 13 weeks, facility-based, improved lymphedema outcomes as well as body composition and prevented functional status declines. But unfortunately, the Wiser Survivor trial, which was home-based, was ineffective for all those outcomes. So in conclusion, in these multi-ethnic cohorts of breast cancer survivors, it is recommended that we start with supervised facility-based exercise because these are superior to improved lymphedema and related outcomes. So to close out our entire hour-long presentation, what I wanted to show you was the model from the review paper that I alluded to at the beginning of my presentation. And so what we've got at the top is what happens with cancer survivor? What does recurrence look like? And what is the likelihood of adverse treatment effects? And we know that these differ, the recurrence rates and adverse treatment effects differ by race. So the question is why? Why do they differ by race? And so what we thought was that the most proximal reasons had to do with obesity and comorbidities and likely some genetic differences in some individuals, but that these issues were likely driven very largely by upstream issues related to societal structures, individual level risk factors, and interpersonal relationships. And I think that Dr. Dean's work, which I showed you early on in my talk, would agree, would give lend credence to those hypotheses. So in conclusion, I'll just acknowledge that the kind of work that gets done in my lab, as well as what you've heard from other presenters, takes a village. So I'll acknowledge a number of extremely important partners and turn the gavel back over to my NCI colleagues.
Thank you so much for that outstanding presentation. I think we're just on the minute, but I'd just like to say that we've had 3 excellent examples of the 2 conditions and the overlapping disparities. We had a large clinical trial, which has proven to be extremely adaptive and sensitive to the needs of various populations. We've had a talk that has focused on a specific target population of underserved populations and having identified the challenges in that particular catchment area. And finally, an interesting presentation on an adverse event that's associated with one of our diseases, and interestingly having identified a particular expertise that seemed to have enhancement of communication skills that was very effective, which I found quite interesting. We're now going to open up our sessions for questions, and if I can get there. So the first question is directed to Dr. Ligibel. How did Dr. Ligibel decide on the time from diagnosis for eligibility criteria? And the second part is, why exclude HER2 positive patients?
Sure, absolutely. So in terms of the time from enrollment, we really structured the study to be developed in the same way as an adjuvant trial for breast cancer, where we were thinking about a medication or a radiation or surgical technique. And so in order to develop our power calculations, we used event rates that would occur in that period of time starting from diagnosis. And so we wanted to enroll patients close enough to diagnosis that we did not miss the early events, because we recognize in breast cancer, there's sort of a bimodal timing of events. You have a population of patients who tend to have earlier recurrence, and these are often patients with triple negative cancers and some of the luminal B hormone receptor positive cancers. And then you have a second group of recurrences that tend to occur later, and these are often the luminal A hormone receptor positive cancers. So we really wanted to be able to look at both of those groups, and that required that we had enrollment be fairly tight to the time of diagnosis. And so that is how we decided on that. Now, I will say that over time, we relaxed that a little bit as we found that modern treatments often extend beyond the 12-month mark, especially in patients with triple negative breast cancer who will receive neoadjuvant therapy, surgery, radiation, and then often adjuvant capecitabine. And so over time, we did extend that window a little bit so that we were able to include some of those patients as well. In terms of the second question about HER2 positive patients, when we designed this trial, there were very few data that looked at the relationship between body mass index and outcomes in the HER2 positive subset of patients, but those studies that had looked at that had very inconsistent outcomes. There was actually just an analysis that was published in the JNCI over the last week or two that suggested a more of a consistent relationship, now that there are more data available, between body mass index and outcomes in HER2 positive patients, but that was not available when we designed the study. And then the other factor is that those patients receive sort of prolonged adjuvant therapy. It extends out to a year. And so we really wanted to be able to, again, enroll patients within a relatively consistent time frame. And so that was why we had decided to omit the HER2 positive patients from the study.
Thank you. So the next question goes to Dr. Matin. It's asking for an explanation because the audience, the question, we do not see in the intervention strategy the following: income management with budget, education, attainment to get a GED or community college degrees. And so they're asking for an explanation of that.
So I'm wondering if that's in reference to the one slide that showed the obesity level as pertains to high school education. I know within that data, there wasn't the presence of that. And I know certainly within our interventions within the community, we've tended to obviously focus more on the dietary and health aspects, because certainly addressing those inequities are a little bit more complex, and I think goes kind of beyond what we can do as a health system and as an NCORE.
Thank you. And Dr. Schmidt, have you partnered with faith communities? And if so, can you share what those partnerships look like, and any outcomes that you can report?
I have. Women of Faith and Hope is a remarkable organization in the Philadelphia area. And, we went to them early on when we were doing the PAL trial. And, I didn't know, I wasn't going in trying to make a formal partnership. I was going in saying, you all are this community, teach me, help me to know, how to interact with folks here. And that it really became like they were my mentors in the community. And they read letters before we would send them out to the community. They did presentations. We participated in a number of their activities. So it became very much a symbiotic relationship. And that just continued the entire time through, that and as well as the Wiser Survivor trial.
Thank you. Dr. Ligibel, what were the qualifications or educational backgrounds of the health coaches?
That's a great question. And we have 15 coaches that are working on the BWEL study, and they have a variety of backgrounds. The bulk are registered dietitians, but we also have a couple of exercise physiologists, a few nurses, and a social worker. And all of the individuals had prior coaching experience, and they also went through about a 6-month program for training in the protocol, as well as training in, most of them had not worked with breast cancer patients prior. And that was actually the hardest piece. I think training on the intervention was relatively straightforward, but training individuals to work with a higher risk group of breast cancer patients was a little bit more of a challenge. I was very fortunate to work with Linda Delahunty, who was an individual, a dietitian and researcher who had worked on the diabetes prevention program and the Look Ahead study. And so Linda really helped to manage the call center in terms of the training and the certification of the coaches. And throughout this entire intervention period, we've had weekly meetings where we have reviewed calls from all of the coaches on a regular basis to kind of look for strengths and weaknesses. And Linda has also done both an initial certification of the coaches based on their performance on a number of key calls, and then a yearly recertification.
Thank you. Let me follow up on that with, how did you decide the BMI of greater than 27 for your criteria for inclusion into the trial?
That was actually the topic of a lot of discussion as we were planning this study. So most of the data linking body mass index to outcomes really looks at obesity, so with the threshold of 30 kilograms per meter squared. But we also recognize that a lot of patients with breast cancer gain weight in the years after diagnosis. And so we did not want to omit individuals who are sort of close to obesity and potentially would become obese over the period of their breast cancer survivorship. And so we ultimately looked at some spline curves of where you started to see the increase in recurrence and mortality associated with BMI, and that was how we chose 27.
Dr. Matin, do you have any hints as to why your rates of obesity in Blacks are higher than Blacks in other parts of the country?
Yeah, no, I think some of the work that with Dr. Shepard and group have done, I think part of it has been, I think, lack of access to awareness, education, and these factors in some of our southern counties where there is not as much formal training or education or awareness regarding these things. I think along with that are some of the dietary habits in our region as well. So I think it's probably a combination of some of those things. But we have found that with engagement and with education, those are things that we are able to improve. But I think it's a combination of those above factors.
Thank you. Dr. Schmidt, does strength training improve lymphedema not associated with cancer treatment?
Oh, interesting. There would be no reason for it not to. The only thing I would think would not work there would be there is a version of primary lymphedema that is genetic malformation of the lymphatic vessels, and in that case, I have absolutely no idea. But lymphedema that would be caused by other traumatic events should respond to strength training just the same way as breast cancer.
So this is for the panel. Please explain if the nudge theory, flexible and modern concept for understanding how people think, make decisions, and behavior toward their money to buy health foods in a food desert would help in the obesity intervention. Anyone want to take a stab at that? Let me repeat the question. The nudge theory, if anyone is familiar with it, flexible and modern concept for understanding how people think, make decisions, and behavior toward their money to buy health foods in a food desert would help in the obesity intervention.
I think that the evidence base that I'm aware of for trying to change and shift the issue of obesity and for increasing physical activity, for that matter, I'm really very convinced by the evidence that we need multi-level interventions. And so I think that nudge is one level. That's a interpersonal level of change, but I think that changing interpersonal without changing the food desert that you referred to, without changing the environment, without changing community opportunities for being physically active, without changing access and competency and education. I think it's a spit in the wind. I think we need a lot of levels in order to change these very intractable issues.
Right. I would second that. And I think part of it also at some level potentially has to be at a higher legislative level as well. I think there have to be some changes made because obviously a lot of companies and otherwise, shops are going to follow what's economically good for them, but there have to be certain incentives put in place so that some of these communities have access to some of those things. And certainly education is a huge part, that once you have those avenues open to the population, to those communities, helping them make better choices and educating them on the short-term and the long-term benefits. So it's not just one particular area. I think it has to be targeted at different levels of society to really have sustainable benefit.
Thank you. I'm sorry, go ahead. Another comment from the panel. Dr. Ligibel, how was the heterogeneity of the interventions and activities, different activities that patients chose to engage in, accounted for? And congrats on your study, and when are your results expected?
So I'll take the latter part of the question first. So we are very hopeful that we will have our primary analysis completed in 2024. Obviously, this depends a little bit on the rate of events, although this is a fairly high-risk population, and we have definitely been starting to record a number of events. So we believe that it will probably be around 2024. In terms of the how we adjusted for differences in the intervention, I think this is really one of the places where, when we designed the study, there was a lot of question about, were we studying a particular dietary pattern, or were we going to be able to kind of differentiate the effect of weight loss versus physical activity in this study? And one of the things that became very clear in terms of developing a study that was feasible with a sample size that was not 20,000 people was that we really needed to kind of focus on weight loss. And this study, therefore, really focuses on what is the effect of weight loss on outcomes. And it is not going to be able to answer the question of whether a low-fat or a low-carb diet is more important, or answer a question of whether physical activity is an essential part. We are certainly tracking behaviors. We are following 24-hour dietary recalls, accelerometers, self-reported physical activity, and we'll be able to look at all of those things. But the study itself is really designed to look at the impact of a weight loss intervention that's designed to optimize weight loss in a particular patient on the outcomes of interest.
So this is for the panel. What or which of the dietary and exercise programs for cancer patients are supported or funded by Medicare or Medicaid?
Silver sneakers.
Yeah, not aware of anything, any of those programs being funded, sadly.
And I think actually that is one of the compelling reasons and why we designed the breast cancer weight loss study. When we started this, a lot of comment that we received was, well, we already know that losing weight by eating more healthfully and exercising is good for people and it's important. And there are observational data in breast cancer that this is most likely important for people. So why do the study? And one of the major reasons was we really need that level of data to be able to justify third-party payment. It's one thing to tell a patient, yes, you should lose weight, you should exercise more. It's another to be able to have a tool and have the means to help that person do that, because I think we recognize that just giving advice often does not really have the types of outcomes that we need for our patients. And so that's one of the hopeful outcomes of our study, if we're successful, is being able to provide the infrastructure for people to make these changes.
Can I just jump in and say that I think that one of the things that Dr. Ligibel has done is protocolize this in a way that is palatable to community oncology in many, many settings, and proven that. And we keep hearing, I keep hearing, and I'm sure she's hearing, well, what are we going to do now that this is gone? We don't want this to go away. So I think that I am hopeful that Dr. Ligibel will be open to partnering with the appropriate people to explore possibly the implementation science aspects of how do we disseminate and make something like BWEL happen on an ongoing basis.
So here's a question to all. How can we better integrate exercise referrals and prescriptions into the clinical standard of care?
Yeah, so I guess that's where, again, the same part that the data comes in, what the work that Dr. Ligibel and potentially goes on, that Dr. Schmitz and other people do, is the more data we have, the more, I guess, armamentarium we have to potentially be able to do that, and then make it something that's, part of integrative health within cancer centers and beyond. Becomes formalized, but I think it starts with having the data to to prove that.
Yeah, I would say that I think we have a lot of the data. I think that the evidence that we need to do it is there. Not that we don't need more, not that we can't get better at that, but I think that I'm increasingly convinced that I think we've relied way too much on oncologists to speak up and talk to the patient. And I think we need an infrastructure. We need, you all probably know what a Rube Goldberg machine is, but if you can imagine, the patient is the ball and it flows and travels and it automatically ends up in the same place every time. We need a system, we need a throughput somehow that the patient will automatically end up with the kind of exercise or rehabilitative intervention that makes sense. And we have those kinds of systems. It's not like we're inventing this out of whole cloth. We've already done this for psychosocial distress. There are already places doing it for tobacco cessation. We just need to repeat this for exercise.
This is for Dr. Schmidt. Has your intervention for lymphedema been adopted in non-research clinical settings?
Yes, so those 700 sites that I mentioned, it's more than 700 now. It's probably over 800 at this point. Those are just clinical sites. And actually, Strength ABCs has been adopted by the largest for-profit organization in the country that does cancer rehabilitation. Select Medical has adopted Strength ABCs as their breast cancer rehabilitation protocol. Yeah, it's all over the place.
Thank you. Dr. Ligibel, have you considered in your secondary analyses to explore the rate of weight loss on your outcomes?
Yes. So one of our secondary outcomes is looking at the relationship between weight loss and overall survival, recurrence. And so we were planning on looking at both the degree of weight loss and sort of the pattern of weight loss. I think the other thing we're very interested in is weight regain and trying to get a sense of, if you lose weight but you gain it back, is that the same as not losing weight? Kind of looking at the overall weight trajectory over time.
Okay, thank you. Will you consider allostatic overload, the wear and tear of external forces that affect particularly Black women, as a possible strategy in future obesity interventions with the intersectionality of obesity and cancer?
That is an interesting thought. I will admit we have been thinking about where to, one of the things that I think we were hoping in terms of the BWEL trial to be able to kind of do some secondary analyses about success of the weight loss intervention by race and ethnicity. And I do think that we have a large enough cohort of Black cancer survivors in our study that we'll be able to look at that. I think where we were a little bit disappointed was in our the recruitment of our Latina breast cancer survivors, and we had hoped for a larger population in that group. And I think that we've been thinking a lot about further work in both populations, but especially involving Latina breast cancer survivors to determine what the most successful interventions are. I think we found a lot of barriers in our trial related to language in terms of enrollment. And I think looking at Dr. Schmitz's work and really working in communities was something that was harder to do with the study of the scale of BWEL. And so I think that in future work, we'd like to work more on the community level and be able to kind of study some of these more specific factors in terms of the success of these interventions in different populations.
So a question on the enrollment of Hispanics. You had a central counselor. Were you able to determine if there were differences in the origins of the Hispanic populations? In other words, disaggregating them, Puerto Rico versus Central America. Were you able to comment on that at all? Were there any complications in terms of the language interpretation or delivery among
That's
the
an
population?
excellent question. And we do have some information that has not yet been analyzed about the origin of the different groups. I think what we found, our entire intervention and all materials were available in both English and Spanish. It was more involved process than I had anticipated when we started the study to gain approval for all of those materials. And that led to a delay of almost 2 years in being able to open the Spanish language intervention, which I know was detrimental to our ability to enroll patients. We also found different psychosocial stressors and in terms of availability for calls and so some of the socioeconomic factors that impacted not just our Latina breast cancer survivors, but we had a lot of individuals whose job and work schedules were more variable, that were working more shift work that would change. So we had more difficulty at times, even after enrolling patients, in being able to keep them engaged in the intervention. And that is something that we're really delving into now. We employed a lot of different strategies while the trial was still enrolling to try to, we developed recruitment materials specifically for different communities, especially in Black and Latina patient populations. And we tried to work specifically with clinics that had a higher proportion of these patients. But I think that sometimes in a study of that scale, it's a little bit more difficult to really be on the ground and develop the types of relationships that you need to be able to enroll as many patients as we would have liked to.
Just one last question. I don't know if each of you want to address it. It goes back to what policy or policy shifts in healthcare do you think would be most impactful in mitigating disparities in the topics that we've covered today?
I guess there's so many, but if I would have to pick, I think something centered around access to healthier foods for individuals in those communities would be one that I would pick out amongst everything else.
Great.
I agree. And I think sort of more focus on preventative care and better reimbursement, whether it's the primary care physician or somebody in an oncology clinic, more support for referrals to nutrition. I think that, the problem with a lot of this system is that it's just underfunded and it's not accessible to a lot of the patients that we care for.
Yeah, actually, I'm sort of interested in the line of reasoning of saying that, it could be that the way that we got physical activity and nutrition interventions covered for cancer patients is because it will reduce disparities.
Great. Thank you for the audience for all of your questions and the panelists for your prompt and outstanding responses. And I'm going to turn this over to Dr. Barbara Dunn.
For listening to these three wonderful researchers. And I have to say, particularly from the Q&A, I got out of it that can't stop with research. We have to develop methods to communicate the beneficial interventions to the community so they get taken up. I think it's just, these were wonderful talks. And thank you, Worta, for managing the Q&A. It was just wonderful. So now you can see on your screen the title of the next and final session of our obesity, cancer, and health disparities topic, which will focus on population community-based behavioral research, including food insecurity. So I thank you, everybody, including all our attendees, and we hope you got out of it as much as I did. Thank you very much. Bye-bye.